Good morning, Amravati. Firstly, many thanks to Manju and the AMOGS team for this kind invite. And it is indeed a pleasure to be here. So when Manju called me and she said I have to talk about uterine masses and how they affect fertility, I thought I'm going to limit myself to fibroids. The reason being the adenomasis would have been dealt with by the endometriosis person, and sarcomas and other things are so rare that I shouldn't be wasting any time on that in this forum. If it was an oncology forum, I would have obviously talked about it. So here I am presenting some fibroids to you. So basically, a great meta-analysis in 2009 basically said that presence of fibroids definitely affects fertility. It reduces implantation rates and it also reduces your live birth rates, your pregnancy rates. And therefore, fibroids become very important to me as an ART consultant. They are prevalent. They are not as high as 60%, but we still, they will still be seen in about 8% of women of reproductive age group. And in patients that end up having IVF ICSI, 25% of these women will have associated fibroids at the same time. The FIGO in 2011 tried to subclassify them into 10 types. The classification and description is widely available on Google, so I'm not discussing this slide, but I'm going to go on to the next one. Sorry. Okay, so my slide has got a little misplaced, but it'll come later. Before that, let us see how does fertility get affected because of fibroids. So there are multiple theories through which people say that fertility drops. One is that the uterine contractility does get reduced because the myoma in the uterine muscle disrupts the structure there, and because the structure gets disturbed, your blood flow gets affected. Because the blood flow gets affected, you have a little anoxia there and therefore chronic inflammation. You also end up getting glandular atrophy and ulceration in extreme cases. Endocrine changes also happen because remember this is an estrogen-based tumor. And we also get paracrine changes where you have got vasoactive amines and local inflammatory substances that rise. In addition to this, gamete transport also gets affected. And this is because the cavity gets deformed and enlarged. The contractility we've already talked about. The cervix can get distorted and the tubal ostia can get occluded. So what is the actual effect? So if you have a submucous fibroid, we go back to the FIGO classification there. I have a 70% reduction in my implantation and clinical pregnancy rates. With an intramural fibroid, which are non-cavity distorting and more than 3 centimeters, I will still have a negative impact. I will have decreased implantation, decreased live birth rates, and decreased clinical pregnancy rates, obviously. Subserosal fibroid, the jury is still out on this. People believe that they do not negatively affect the chances of falling pregnant, but your outcome of your labor and your delivery will be massively hampered by them. So the more you read, the more you will know, the more you learn, the more places you will go. And that's what I'm hoping to do with fibroids. So let's read a bit more. So with submucous fibroids, if you take a look at it, we've just talked about the decreased rates, but the miscarriage rates also go up. And this is usually because the HOX gene expression is globally reduced when there are fibroids present, and therefore your global endometrial receptivity goes down. And that is where she will not implant. If she implants, she will have an early miscarriage. With intramural fibroids, especially if they are in the endomyometrial junctional zone, and this is your most important zone, depending on where the fibroid is in relation to this zone, your treatments will get decided depending on that. Even when they do not distort the cavity. So now you got enough data on one hand that says that there are negative effects on IVF, but there are also enough papers that say that there are hardly any effects on IVF, or the effects are not statistically significant. And therefore, we now need to take a look at the size of the fibroid to see and decipher these papers further. So if the size is more than 5 centimeter, obviously the IVF outcome is negatively affected. And therefore, they should be removed pre-treatment, and that is the consensus that people have made as of now. This has been challenged by a recent paper, which is going to be at the end of my talk, but this is what most clinicians will do as of now. Intramural fibroids less than 5 centimeters. So this basic meta-analysis that looked at less than 5 centimeter growths, they have not been able to decide whether they should be disregarded or should we operate them. If we operate them, at how many numbers do you operate them? And do you operate them before your IVF or before your transfer? I mean, what do you do? Or for how many failures do you wait before you decide to operate them? So the jury was out on that until 2001. A few of these questions have been answered since. Intramural fibroid less than 5 centimeters. Basically, multiple papers that say no differences in your live birth rate compared to your controls. A great paper by Olivier in 2004, Fertile Sterile. This is a great paper, read it up. But they took a look only at one cycle. They did not take a look at what happens over cumulative cycles, because the people who fail are going to go with the second cycle later on. And Khalaf in 2002 actually took a look at this. But the data from here, the number of people that were included in the study was less, but still they give us some information that the controls tend to do better than people with the fibroids. And that is what that particular paper says. So then people thought, okay, 5 centimeters we know, and then less than 3 centimeters becomes the cutoff. Let's take a look at what happens if we take a 3 centimeter cutoff. Obviously, clinical pregnancy rates tend to be lesser if the myoma size is more than 3 centimeters as opposed to less than 3 centimeters, as well as the miscarriages tend to go hand in hand with there. A subserosal myoma, we've already taken a look. The impact is not significant. Sometimes the questions do get complicated, but the answers are pretty simple. And for this, we need to go back to what our clinical experience has taught us till now. So if I have a distorted cavity versus a non-distorted cavity, personally, irrespective of the size, I'm going to try and correct the cavity. And that is what your papers say. So a distorted cavity with a non-distorted cavity gives you better success rate with IVF than a distorted cavity does. Outcomes in non-distorted cavities. So even when the cavity is non-distorted, if your myometrial endometrial junctional zone is affected, you have adverse pregnancy outcomes. And this is not only for the pregnancy, but also for your IVF outcomes. Does the size of a non-distorting myoma matter? So no, it doesn't matter. Everybody agrees that the adverse effects will be present if you have a myoma that affects the myometrial endometrial junctional zone, irrespective of its size. Do the number of fibroids matter? So yes, if you have lesser number of fibroids, you tend to have a better outcome as compared to if you have more number of fibroids. There were some papers that looked at the total mass of fibroids. So if you have got 5 fibroids, 1 centimeter each, making a 5 centimeter mass, versus you have 2 fibroids that were 3 centimeters each, making a total mass of say 6 centimeters, your number of fibroids, 5 fibroids gave you a poorer result than your 2 fibroids. So those are, but those papers are again not very clinically robust. Distance from the endometrium, and this is what I'm harping about, your endometrial myometrial junctional zone. Whenever the distance between the edge of your fibroid that you can clearly see on a good quality 3D is lesser than 5 millimeter from your endometrium, you are definitely going to get poorer outcomes as opposed to when it is more than 5 millimeters. So what do we want? What do my women want when they come to me for treatment? There was a good American study in 2013 that basically said 2 things. They want their uterus preserved and they want their fertility prospects to be kept open. And that is what they're looking at. And that is what we need to give them. So therefore, my therapies then get divided into surgical therapies, minimal access therapies, and medical therapies. And my decision making completely depends upon childbearing requirements, age, how severe the symptoms are, is there a risk of malignancy, is there something else happening there, and how close is she from the menopause. And that is what is going to help me decide what I'm going to do with her. But none of my minimal access therapies have actually covered the need that I have for a successful complete treatment, especially keeping fertility in the equation. So let's take a look at medical management. Yes, we've got data that says that medical management, especially when she's trying for infertility, we don't really have much time there to waste. Don't waste her time, get on with it. There are some case reports with ulipristal as an adjuvant prior to myomectomy, following which you can go ahead and do your transfers. And data seems to be beneficial at this minute, but we don't have bigger studies, so really can't go down that route clearly. Take a look at uterine fibroid embolization or MR-guided focused ultrasound to shrink the fibroid size. Yes, they will help the fibroid and the symptoms, but they are not going to really help your risk of miscarriage. Your risk of miscarriage remains high. So now, therefore, let's take a look at my surgical options. Myomectomy. Try and get your patient pregnant within a year after you remove the fibroids, because the chances of falling pregnant will sharply fall after this. And therefore, time your surgery in sync to go with giving you the best option once you've done it. So if I do a myomectomy in somebody who wants a baby and she's already more than 35 years of age, my pregnancy rates are poor. The more number of fibroids I have removed in this woman, I get a lesser pregnancy rate. If it's a posterior wall fibroid that I've had to remove, I'll get a poorer pregnancy rate. More than 8 centimeter fibroids and correcting a cavity to maintain its shape will give me better pregnancy rates. And that brings me to Metwali 2012, who actually went down to scoring the myomas, and he said, how deep is the myoma, how wide is its base, what is the size of the nodule, and where is it placed in relation to the lateral wall. The higher the score, the more aggressive treatment that you need, and the poorer outcomes you get irrespective of treatment. Please take a look at this paper, it's really fantastic. Zepritis et al. In 2016 actually classified things after Metwali's paper and gave a more clear-cut guidance of what to do at what stage. Both these things are easily available on the net, so just read them up once because I'm falling short of time now. Serur et al. Said that myomectomy and ART, you cannot decide at this minute which goes first, so you choose depending upon your patient, individualize it. Submucous fibroids, remove them irrespective of the size. Intramural distorting fibers, definitely remove. Subserous, you can leave them. We've already discussed all this. And lastly, 2 meta-analysis, and this is what turns all the data that you have till now completely on its head, because what they say is that surgical treatment for fibroids really don't make any difference to their fertility outcomes, and therefore they say go ahead and do your surgery and don't basically put them go ahead and do your IVFs and don't really put them through any surgeries. So these are 2 papers from the same people. One meta-analysis 2012, one meta-analysis is 2016, and they've actually come up, this is a 2020 January meta-analysis. They've added a few papers and they've come up with the same thing. They've also taken a look at myomectomy versus no intervention, limited evidence, laparoscopy versus laparotomy, or versus mini-lap, limited evidence, monopolar versus bipolar, limited evidence. But yes, you will succeed. At least 98.34%. Thank you and Jai Hind.